wife. Welcome. We're back.
Puerto Rico. Esta bomba yo la dedico a toda mi gente de Puerto Rico, a la familia Fontanet, allá en Cumbe Alto y Lo Mejía en Vega Baja. ¡Que gocen! ¡Sí! Bomba, bomba, para siempre. Bomba, bomba, está presente, aquí lo canta mi gente. Bomba, bomba, para siempre. Baila, baila
You keep us on schedule. You're good.
Get out of here. We got to sit down. So my daughter went to Carlton. She went to Carlton. She loved it. And then she loved Minnesota so much. Oh, wow. She graduated. No, she's in Minneapolis.
Can I do
Invite me, yeah. Oh, yeah, no. Staging.
I could be Uncle Alan and Sue.
Oh, that's so sweet. Yeah, she graduated in 2015.
I'm serious. I mean,
Oh, I do. I love Minneapolis. Last time I went, we went to It was good. It was really good.
A lot of people,
Oh, you are?
Yeah.
Well, tell me.
a lot of people sort of like,
We can go out
they
for a
come
drink
back
there
later.
for sure. Come over if you want to. Come. I didn't even know what it is. Yeah.
I don't want to break that the engineer.
Yeah. Yeah.
You can email. I mean, I've got yours.
Pardon me?
Just have a contact.
Yes.
Okay.
I mean, if something comes up and you don't have family or something, why not?
That's
Well,
very sweet.
we're gonna, well, it will be early. I don't know how.
I was going to almost call you last time.
Thank you. We're going to start our afternoon discussion, and so I welcome back the panel. And just to remind you, we have an hour now for discussion among the panel. And we can talk about any of the things we had been talking about, but in particular, we'll be voting after the hour of discussion. So if there are any unresolved questions, including about any of the voting questions, now is a good time for us to talk about it. And it seems like some of the issues we talked about were composite outcomes, primary endpoints, secondary endpoints, surrogates, mortality, quality of life in a broad sense, or disease-specific quality of life. Just throwing out a few of the sort of major threads of our earlier discussion.
I'd actually like, this is Lynn Stevenson, I'd like to revisit Eileen's question from this morning. What is your hope of what we will come up with? Because it's not going to be this one measure is going to work for no matter what your therapy is and no matter who your patients are. That's not going to happen. So without that, what is it that you are looking for in your answers to these questions?
And are you directing that to Joe or to me?
To anyone who has helped put this
Want to
together.
take a Joe or I'm happy
But
to
Joe,
talk
that
about
would be helpful for all the panelists.
So I think just looking at the endpoints in general, in the context of the population that we look at and the studies that we review for potential decisions. So I think sort of mentioned earlier, it may be specific populations, but I think overall is what we're trying to look at, and from that standpoint, if there are really some characteristics or factors that need to be mentioned specifically, I think that would be helpful. But in general, I think if you can say what an average beneficiary is.
I guess I had a kind of a follow-up to that is the voting questions are the standalone. And I was a bit confused originally that the standalone, because there's a footnote about mortality. So when you're talking about standalone, do you mean standalone with mortality? Which is not the definition of standalone, but this is Swain speaking. So, because if you're going to say standalone without consideration of mortality in the primary, you might just want to ask if anybody in the panel would agree with any of that. And then maybe the questions ought to relate to, as a composite with mortality, all those questions you have.
So I think we accept mortality, and that's the one we actually will favor in many instances. I think it's really if it's not studied, what else could be an endpoint, a primary endpoint that would be important.
Instead of.
Yes.
Right, but that's a big issue. I mean, because from a planning point of view, as I think we saw, there's a big difference in time and expense for planning for mortality than there is for planning for any of the other endpoints.
We're confused.
Yeah.
You're asking this question about truly standalone, and mortality is not in the primary endpoint.
Yes.
Yes, okay.
The other question, I'm sorry, it's a similar vein, are we considering research in the broad, like a broad category? That is to say, are we considering all types of studies? Because it is, I mean, what the panel or the speakers describe is that endpoints like quality of life and function and perhaps hospitalization might be better than mortality in these cases. But then biomarkers were mentioned, but those may not matter to patients. But biomarkers and surrogate intermediate outcome endpoints may be better suited for phase 2 studies for that matter. And so is it the question broad enough to include all phases, or is just phase 3?
I think it's a broad approach, including all phases, because I think as was mentioned this morning, as we see really new, technologies or new developments earlier in the product development cycle, I think we're seeing earlier studies.
Right, although generally Medicare is only talking about approved studies, so it wouldn't be early phase.
So same question. So we're really talking about approval for beneficiaries. We're not advising the FDA today.
No, we're not advising.
From that vein, it refers to phase 3 approval.
Well, I think there's some instances where, depending what type of study has been done for their marketing approval, it may not actually be a phase study, I think. So there could be some of the initial studies that we see actually are earlier phase studies than we typically do.
It was,
Now I'm confused.
yeah.
The IDE trial.
I mean, right, I thought Medicare criteria were reasonable and necessary, and so
Right.
that's what we would look at, which to me is the more fully developed.
Well, and Joe, one more thing is, back to the setup for this, it's not just phases. That's the classic regulatory sort of FDA approval environment. This also includes observational studies and other forms of data, correct?
Yes.
As we talked about. So it's a broader evidentiary category than simply clinical trial phases, right, everybody?
I would ask, Dr. Zuckerman from the FDA to
Yes.
perhaps explain a little bit more about the situation sometimes we encounter.
Sure. It's a challenging one, and we certainly appreciate everyone's efforts here. And that's why I would go back to the Ferreira article, the central illustration, or put Dr. Adamson's slide on the board, because the reality is that although one size doesn't fit all, many cardiovascular devices will be coming through the expedited access pathway. As part of the 21st Century Cures legislation, Congress has mandated that the benefit risk assessment of device technology proceed in a way such that we can optimize patient access. And certainly I would encourage people to look at the FDA website regarding the expedited access pathway and look at the Ferreira article. But the bottom line is that for many Class 3B heart failure devices, the FDA trial paradigm is to assess the following in terms of effectiveness. There are 3 intermediate endpoints that must be separately met in different categories to avoid some of the problems with composites that were talked about this morning. In addition, the trial is designed as an adaptive Bayesian trial such that we would have a certain predictive probability regarding mortality and hospitalizations. Now, it's not the traditional predictive probability that you would assess in a 3,000 patient heart failure drug trial, but it is enough to potentially present an FDA approval with the hope that the randomized trial continue to show a more precise reduction in heart failure, hospitalizations, and mortality. At this point, the data would be presented to CMS. So we're trying to develop a unified system for that particular device technology, which I would put as Class 3B. But I would emphasize that one size doesn't fit all. Certainly, people are well aware of the LVAD technology, and that really requires, I believe, a different trial design, but the panel is here to question that, as well as what Dr. Adamson referred to this morning as the early diagnostic monitoring systems. Certainly, both FDA and CMS are interested in being able to properly assess diagnostic devices that hopefully prevent this continuous spiral from class 2 to 3 to 4 with early warnings. And this has been a very controversial area of device development and assessment. Joe, does that help you?
Yes, thank you.
I'm going to make a comment, and then I'm going to start getting everyone involved.
I just have one, I just didn't understand the last thing you said with class 2 to 3 to 4. I didn't understand what you were saying.
Okay, with better invasive monitoring of heart failure, there's the hope that we can stabilize patients so that there's not this inexorable progression of heart failure disease that really confronts the country. It's really a public health dilemma right now.
Thank you.
So we can talk more about it, but there's certainly a lot of tension, I think, between wanting to get effective therapies to patients soon and not wanting to have ineffective therapies or harmful therapies. And it's particularly a tension, I think, for devices, and particularly implanted ones, because I don't think FDA, I don't know of any devices that get pulled off the market when we find out that they actually didn't work or they're harmful. And I don't think right now post-marketing, while we've talked about it, I don't think it's robust at all. And so that means essentially we're putting untested or minimally tested and possibly unsafe devices in patients that are now permanently implanted. And that's essentially what this early phase is, and then we find out, or we don't, that they're harmful, and then we have lots of patients that have harmful devices implanted. That seems like a problem.
Dr. Redberg, may
Yes.
I reply to your
Sure, Dr.
key
Zuckman.
statements?
And then,
Certainly, Dr. Redberg's comments are extremely important, but I would advise you that we're here to be reasonable because we have a very important public health mission to try to grapple with. I believe what Dr. Redberg is speaking to is that technically no PMA approved device has ever been pulled off the market by FDA. But that doesn't mean that the rigor of post-market surveillance has not increased within the last 5 to 10 years. For anyone in the interventional cardiology arena, I think at last week's ACC meeting, you're probably aware of the safety communication that went out with the Abbott bioabsorbable stent. I think many of us are aware of the post-market surveillance that's been done with our CMS colleagues in both the TAVR and LVAD arena. So I would be the first to agree with Dr. Redberg that post-market surveillance at this point in time is not perfect. It was a key area that Dr. Califf, our recent commissioner, was working on. But I would also encourage all of us to look at the recent JAMA editorial written by Drs. Califf and Shurin, where we talk about the NEST initiative and the significant changes that we do believe will occur with post-market surveillance in the next 5 years. So while nothing is perfect, I think we have a lot of tools to work with and to have this panel dive into. Thank you.
All right. Thank you, Bram. So I think that's where the context of really then looking at the specific endpoints that we see for our determinations of reasonable and necessary items and services.
Thanks. Dr. Zuckerman, then Swain, then Siegel, and then we'll start.
Thank you. I wanted to bring up the article that we were given to look at by Desai et al. Because it purported to show the effectiveness and the importance of hospitalization as a standalone measure. And yet, 3/4 of the patients disappeared before the 12-month follow-up data, and almost half of them were gone or never entered into the 6-month data. So I was concerned about that. I mean, there were other shortcomings of the study that the authors pointed out themselves, and also that in the accompanying article by Harlan Krumholtz had pointed out. But so in addition to the problems of using billing data, and you don't have very much information about the patients, you know very little about what's actually going on with them. But in addition to those big issues, the fact that they started out with 1,900 patients, but only 1,100 were actually studied at the 6-month point, which was the first point, and then you lost more than half of those, so it was about 500 at the 12-month. And I just wasn't sure how you could do much. And then there's, of course, no control group, because the patients are their own control group, I guess. I don't know how you can draw any conclusions when you've lost 3/4 of the patients and you don't know why. And you can't know why, because it's billing data.
So you're raising concerns about the current status of our post-marketing efforts.
And I want to know if I was missing something. I didn't see anything about...
Dr. Zuckerman, I'd like to correct one thing that Dr. Redberg just said. That's an interesting article to discuss because of the methodological problems inherent in the article. However, I'm sure everyone doesn't have to have time right now to pull the CardioMEMS summary of safety and effectiveness, which is on the FDA website. But that is not the post-market study for the FDA, for all the reasons that you just pointed out. And certainly we can go into what the specifics of a post-market requirement would be, but it's really important to underline that this is an interesting article, but is not FDA post-market surveillance.
But is the FDA post-market study a peer-reviewed published article?
Excuse me?
Is the FDA post-market study, is it a peer-reviewed published article?
No, it's an ongoing PAS study right now.
Right. So the data then is not available to clinicians.
The data is being monitored right now. If the company wants to make the data available at any forum, that's their ability to do so.
So it's in the company, but it's not available to clinicians. Is that correct?
That is correct.
Right. I mean, last year or so, we had the Intermex meeting to review the post-marketing LVAD Intermax data, and we had a discussion, and that's held, I believe, by University of Alabama. We had specific questions. Medicare if I was reviewing the data beforehand and I had specific questions, I was told we could not address them because we could only address what was going to be released by University of Alabama. A lot of the questions of the panel on that day were not able to be answered because it was a very limited set of data that Medicare was given as part of this post-market study. And then what really struck me was about 6 months after our MEDCAC meeting, the Cleveland Clinic, I think in conjunction with University of Pennsylvania, published a study on their problems with LVAD pump thrombosis that was a fatal error. And none of that had been discovered in the post-marketing Intermax registry that we had discussed 6 months prior. And I haven't, so that's what gives me concern about our current post-marketing. I did certainly read Dr. Califf and Dr. Shuren's article, and I'm very glad to hear about it, but I haven't seen that post-marketing improvements yet. And therefore, as I said, as devices get implanted, I'd like to have the effectiveness and the post-marketing in place first.
Yeah,
So
I just wanted to add that with
Sorry.
Dr. Califf gone and the newly nominated commissioner having a very different view of regulatory science, we don't know what's going to happen next.
So I just a comment. I think that's discussion has been interesting. I'd just like to try to refocus that. I think that one article was background material, and we didn't really want to focus on any particular device. So I think just keeping it in a broader sense.
You know, Joe, just to say it, to get us to move along, it sounds like, again, we're not here to discuss particularly the post-marketing surveillance that our FDA does or what it will be in the future. We're not here to discuss new regulatory supervisors. We're here to actually look at the bulk of the data we know that's available, not one article, and provide advice, right? We
I
should
think
do
that's
that.
true,
Let's
but
use our time to do that.
But the argument for moving up pre-market is that post-market will be better. But anyway, I want to go on because there were Dr. Siegel, Dr. Swain, and then Dr. Sheesh.
So would you just clarify the trials that you're talking about for coverage decisions, that would include the pre-market trials from FDA plus others? Where do those others come from?
So we, in our usual review, we will actually review whatever has been published. We do extensive literature search in sort of the public databases. So they can include all types of studies, the initial studies, the post-market, pre-market.
But you wouldn't go to industry and request trials for coverage decisions, or do you?
Not in our specific reviews. I think our decisions, with coverage with evidence, development decisions, that's a framework for studies. So we don't typically ask for particular manufacturer studies.
Dr. Swain?
Yeah, before I ask about reverse remodeling, just one comment is that, as Dr. Zuckerman said, you don't have any access to any, CMS does not have access to this post-market data. And we have seen, and it's been presented, I presented at a public panel once, one company who had a failed study just changed the endpoint and published it as a successful study in New England Journal. And nobody else knew except that we had a public panel to say that. So it's a huge issue. But what I want to ask about is this exercise testing and the bunch of parameters for reverse remodeling, anything you want, systolic, volume, whatever, is we really need the MCID, minimally clinically important difference, and we need a validated one which needs data. And we just don't have that in virtually any of these. And when you look at the exercise testing as predicting mortality or heart failure hospitalizations, we saw several slides worth of that. And you guys look at the C statistics, the area under the receiver operator characteristic curve. So the rock on these are like 0.6 and 0.7. 0.5 is a coin flip. 1.0 is absolutely predictive. All of these are less than halfway there. So to say that they could be a standalone when none of them have a ROC, a C-stat over 0.76, I think was the best one we saw, is difficult.
Dr. Sheesh? And Dr.
Well, I mean, I think Lynn can.
Did you want to comment, Dr. Stevenson?
For peak
on that one?
oxygen consumption, I actually do think the C index is actually closer to 0.7 for a patient population that's very sick.
Okay. This is Lynn Stevenson. I think it's very important when we talk about these surrogates to define which is really a surrogate, that the patient could care less about their systolic volume or their NT-proBNP. On the other hand, peak VO2 correlates very nicely with patients' level of function and their quality of life. So I think the peak VO2 itself is a self-validated measure of what you can do. That has meaning whether it correlates with anything else or not. Whereas end-systolic volume and NT-proBNP don't have any particular direct relationship. The patient doesn't care what that number is.
Although I think even for the VO2, we saw 0.7 to Julie's point.
Well,
I mean, I agree with you, but I mean, I'm certainly,
well,
there are
but
people that
exercise
have,
capacity itself is sort of has face validity. If you can do more, then there's something that's better. So I think we need to distinguish, we can argue about whether to use it, but we have to distinguish that as we distinguish the quality of life measures from something that has no face validity on its own to patient function.
and I think we have to separate quality of life measures too, because the patient-reported outcomes, I think, are different than surrogate and intermediate outcomes. We've talked about all of those.
So Rita, I want to ask really the group, so our task at hand is to answer from a population standpoint what endpoints and duration. And one of the things that, that is hard for me as a heart failure transplant specialist is that to come up with one endpoint, right? Because I can create scenarios for which one endpoint applies for only one group, okay? When I think about all the wonderful talks we had, we all agree that quality of life matters, all these things matter, hospitalizations, everyone agrees with that. So my question to the group is, Dr. Carroll actually talked about 6 domains for devices. And survival was one. The other was evidence to even support the biological effects or plausibility of this even being useful. And then complications, improved health, functional assessment, and the last one was freedom from hospitalization. Would it be so horrible, instead of looking for one endpoint, that we all, that all 6 of these are met in not one study, however they want to get there, but we need the information to make the best decision. So, I was thinking, what about defibrillators if we went back in time, for which only mortality? But you can also make an argument that it does save someone's life, and when they get saved, the quality of life, Lynn and I may differ. I could be emotionally distressed over being shocked and traumatized for life, and she could be grateful that she was brought back. So I think that the 6 domains that were mentioned are very worthy and necessary for people to be able to make the most informed decision about whether or not this has incremental benefit beyond what we already have. So is that a crazy, I realize that also is cost, right? If you have to actually meet all 6. How do people feel about that?
Any comments on Eileen's question? Bram?
Actually, I think it's a very good approach and is similar to the more inclusive approach that the FDA is taking again, where you have to meet A and B and C and D independently. You avoid the potential problem of the composite endpoint, where one endpoint can drive the whole thing. Number 2, from a practical point of view, you just asked, is it too costly? And the answer is no for the intermediate and or surrogate endpoints that have been discussed, because most of them are continuous endpoints, so the sample sizes are pretty reasonable. So I would really encourage the panel to think along the physiological reasoning that you have just challenged us with.
Dr. Fish.
So my comment has to do with remarks that were made about paying attention to secular trends as it relates to the endpoint of heart failure hospitalizations. And so I was thinking about what we see in cancer medicine. I'm a cancer specialist. And so one of the endpoints that you see with chemotherapy is hospitalization or ER visits related to febrile neutropenia due to chemotherapy. And, back in the day, that's not really an easily biasable endpoint because when your patient got fever and neutropenia, that's where they all went. So at a certain time, that was perfectly fine. But more recently, there's changes in care delivery. So I've talked to practices that will boast, we just don't send patients to the hospital anymore. We've extended our office hours. If they come in on, midnight on Christmas with a fever, and we'll take care of them in the office, and they may spend, 4 to 8 hours of medical time. It'll be a medicalized experience, but it won't be an emergency visit. It won't be an event. And then they compete with other practices in terms of being a really great place to enroll patients on your trials, because your toxicity rates are going to be really low because of the way we've operationalized care delivery. So maybe that's not really doable for an individual practitioner in heart failure if you're going to disrupt your day, and it would be quite a grind to do that more than now and again. But if you redesign your care delivery, you could change what's really happening in terms of the events without changing what's happening in terms of the actual experience of care for patients, right? They'll have medicalized time.
Right. Sounds a little bit like we were talking about before lunch about the subjective endpoint of hospitalizations, that sometimes people would or wouldn't get hospitalized, and it doesn't have anything to do with their condition, but more of who they were seeing.
It's a different subjective.
And what the
so
incentives
there's a subjective at the level of the individual doctor deciding whether or not you go here or there, or what's really the trigger. But then it's a care delivery subjectivity, right? If you have access to a way of doing it outside the hospital, where you got to round in the patient 3 times in a day and adjust a bunch of things, and it's really like a day camp instead of an overnight camp, that's different.
Okay. Dr. Siegel, did you have a question? Yeah. No. Okay. Dr. Sadrakian.
I think I just wanted to comment. I think we talked about a lot of correlations here. We talked about statistics for correlation of the intermediate endpoint with a, say, standalone endpoint like mortality. It's the findings that we're talking about, but we're not talking about influencing that surrogate endpoint. Does it lead to improvement in a standalone endpoint? We haven't seen any evidence, except in one situation, in fact, for the left ventricular systolic pressure, when change of that intermediate endpoint led to improvement in a standalone endpoint. All the rest were associations. This is correlated with mortality, but none of them were about change in that endpoint leads to reduction in mortality. So, and in an example that was presented to us, the clinical composite score, in fact, it has shown that improvement has no value over unchanged. So that was one example that we have seen. And the second example was really about 15% reduction in end systolic volume that seemed to be correlating with mortality. For any other surrogate endpoint, we haven't seen that kind of data. Unless people can come forward and tell us that there is such evidence, I think we should consider that that evidence does not exist currently.
Thank you. Thank you. Dr. Berliner, did you have a comment or question?
I just wanted to, the day started with Daniel Canos talking about some of the efforts in the European Society of Cardiology and ICHOM to come up with standardized data sets. And I looked up the systematic review that Dr. Allen and his colleagues did that informed their work, and so I just wanted to read some of it. Improvements in functional class and quality of life were reported, but missing data complicated interpretation. Adverse events were experienced by the majority of patients, but estimates for bleeding, stroke, infection, right heart failure, arrhythmias, and rehospitalizations varied greatly. So that could partially be due to the subjective nature and partially due to different definitions, and they concluded that it highlights the critical need for high-quality, patient-centered data collected with standard definitions. And I would just like to go back to that idea of having 6 domains. Can we come up with one outcome measure in each domain that would be measured standardly in all studies?
You can't do that for complications.
Microphone, please. Eileen, microphone.
I said you can't do it with all 6 because one of them is complications, which is actually based on whatever device. But I think as you're pointing out, perhaps we can decide about what kind of, when we talk about functional assessment, are we going to do 6-minute walk versus peak oxygen consumption? I mean, if that's what you're asking.
Yes.
It also, but when you do that, it gets a little more complicated because not every hospital has the capacity to do peak oxygen consumption. So that already then, when you try to make it mainstream, you're changing things, the dynamics.
Right, and not every patient is able to do VO2 just because of the apparatus. But what I heard from, I think it was Dr. Bronner, when he talked about 6-minute walk, I heard, and certainly it's my observation, there's some subjectivity to that because some patients are more motivated to walk faster or slower, and some of the people performing the assessments are more motivated to get their patients to walk faster or slower. So, and again, that was, I think, back to, it was ROC of 0.6 and the VO2 was 0.7. And I just know when I was reading echoes full time, I would read echoes on patients who had EFs of 20 and could, run to the echo lab, and I had EFs of 45 and they could barely get out of bed. And that's why and I suspect VO2 is good, but it's not great. I mean, I guess we saw 0.7 for the C statistic.
So
and I think that was probably the best, it seems like, intermediate endpoint that we've talked about, but how good is that? And we also had talked a lot about patient-centered outcomes. I thought that's where you were going, actually, and with your comment of patients don't feel their LV ESV, but they do feel their functional status or their quality of life. When you ask them how is, the Euro quality of life score, or we talked about and we also talked about disease-specific Kansas City cardiomyopathy score, and then maybe we should go back to that discussion because I felt like, people were making the point, well, if your heart failure was great, but the rest of you wasn't so good, was that really great for patients, or should it be a more holistic kind of whole person quality of life measure? And then we were getting into, well, how complicated is it? The SF-36 is obviously 36 questions. Now there are shorter ones because there is time in doing the questionnaire too. And I think it actually decreases data collection. In most of the registries I've seen, my observation is it's the quality of life data that gets least filled out. For example, in TVT, I think it's got the lowest data accuracy and data completeness. Even though we're saying patient-reported outcomes is what's so important, so maybe we can have some more discussion on those. Art.
Can I continue commenting on that question? Because I wanted to talk more about that single question of health transition or self-rated health that we ignored over time because it wasn't giving us the scale that was so measurable, easy to measure and get continuous endpoint that we could put into our regressions. And the methodologies 20 years ago were also not well developed for these multinomial sort of assessments. The single question is harder to use an outcome and also publish as a paper, let's be honest, than scales and sophisticated questionnaire that we're administering. So I think this is really important for us to go back to the basics and think about, are there those questions so meaningful for recovery that we're not taking into account and addicted to the scales and scores for psychometric properties and validations based on some other unmeasured, unvalidated instruments and anchors, while PCORI path that we heard today are meaningful questions from patient perspective, but then we don't know what to do with them. Whether patients are changing their decision or they would change their decision to get surgery, how do we even incorporate into outcome assessment for a device, the change of mind sort of endpoints. So I think this quality of life and patient-reported outcome measures, I think we need to rethink what matters and how long the questionnaire should be, because also the longer it gets, the more bias get introduced because patients get tired and they start randomly filling out things. So I'm not even sure we're getting what we're trying to measure because they get tired and annoyed, while a few questions they would give us a pretty good answer.
Well, just to respond, it's not our job today, I don't think, to talk about the difficulties of creating a survey instrument and the differential effects in how we approach it. That's a methodology thing. I think I'm hearing you say that you believe they're an important outcome. Cut to it.
Certainly, but I think as a MEDCAC panel members, we should comment on the developments that are needed in this field as well, because we've got a lot of certainly smartest clinicians in the country here and manufacturers who are developing these questionnaires for a reason. Any innovator that comes up with a new device wants to find an outcome that they can measure, and then they have to do a lot of marketing. I'm not being cynical here, but that to make it as an important endpoint. So I think we need to be careful and advise the stakeholders on what's best way to measure as well the quality of life outcomes.
So I think I've heard the panel say that we like a single set of short questions that are operationally effective across trials. But I also thought I heard our experts say that the Kansas City questionnaire, maybe the Minnesota Living with Heart Failure, might serve that role. Does that capture what you were saying?
For a disease specific, but
For a
then we were
disease
talking about a more general one.
Can I comment? I mean, I think this disease-specific questionnaires development was tied up to the fact that we couldn't get the effects in a general quality of life measure. So it's more almost like target vessel revascularization versus MI. So I mean, I think there's a history to that as well, how we came up with so many disease-specific measures. I'm not criticizing, they're great, but we need to take into account that why they were developed.
If it's like target vessel revascularization, I don't think that's clinically meaningful. But Marcel, Dr. Saliv?
Yeah, I guess this is a little bit along what Art was saying, but we have a question on surrogate and intermediate endpoints, and I won't go as far as what he said, but I wanted to just put a point on biomarkers. There's a whole thing on biomarkers. No one presented anything to us on validating biomarkers as an intermediate endpoint today that I saw. It's on this chart that Bram Zuckerman pointed to as one of the three things, but I'm not personally aware of BNP evidence. So again, I'm not going to vote for that because I haven't heard anything. So
I think that's an accurate summary.
Thank you. You just saved us time.
Dr. Zuckerman and then Dr. Siegel.
I just want to emphasize, I don't think we should be thinking of quality of life or even functional improvement as surrogate markers. I think they're real. They're as important, they're different than survival, but they're extremely important. They're essential. The problem is finding a way to measure them that's not just valid and not just reliable, but is in a study where there's a control group and you have a sense that you know what you're measuring. I think that the Kansas City questionnaire is apparently reliable and valid, but it includes a few questions that would probably be better off in a separate depression inventory. And I think either the Beck or the Hamilton inventory is only 10 questions. So you could have a separate depression scale, and then you could have a functional scale, maybe using the Kansas City questions. And then you'd have two different valid, reliable scales that measure two different things, and I think they are two different things. But my main point is just that these are really important outcomes, and if we could get a better handle on them, I think they're something we should care about as much as anything else. But the problem is finding that way to do it.
Right, and I think for depression, you have the PQ2, which is just a 2-question screen that is as valid, from what but I'm not the expert on it. Jody, did you want to comment?
Yeah, I feel like I'm still trying to wrap my head around what we're doing. But are we supposed to just assume that the outcomes that are important to patients and clinicians are the same outcomes that are important to CMS? Because that doesn't feel believable to me. It's a very Jody type question.
Joe?
Well, I think that's true. I think it is similar. I mean, so we do really do try to take a patient-centered approach, to our considerations and reviews. So I think there is a lot of synergy, with that.
What's leading to your concerns?
So this is kind of along the same lines. One of the things that we're supposed to distinguish between in the questions is whether we consider general hospitalizations as an endpoint versus heart failure hospitalizations. And one of the things we've debated about is whether quality of life should be measured with a disease-specific approach versus a general approach. And that actually, I haven't even figured out in my head, so I'm going to just talk out loud what is going through my head. So on the one hand, I'm thinking about what Lynn has said about the importance of you can improve someone's heart failure, and yet you may not impact their quality of life because maybe that wasn't driving their quality. So it matters a lot to them whether or not they improve. But we're talking about devices and medications that are going to be reimbursed to treat a disease. And if I use a drug like Viagra that was initially meant for angina, if I was now to constantly start ordering it for angina instead of for its other purpose, that doesn't make sense to me. So I am wondering, does it really make sense to use general hospitalizations, general quality of life, when the devices and medicines are to treat a specific disease, even though the person has more other issues? And I can't figure that out in my head, because I think that it really should be disease specific if the device and the medications are supposed to be treating it. But I do fear one thing. What happens if the device or medication harms? And so you sort of do need a monitor for that. And that's where I'm kind of torn. And I don't know if anyone else has a better way of looking at it, but I think it matters.
Right, and I think that's an important point. I mean, both the disease specific, and then there's the question, well, their heart failure got better, but they felt worse, but was it because of the treatment for their heart failure they felt worse, or were they already feeling worse for something else? And also, we haven't had a very robust discussion of harms, but to have a net benefit, you have to also consider what are the harms of whatever is also leading to the benefit. Dr. Stevenson. And then down.
I think these two questions are very parallel, if we can think about them at the same time, as Eileen did. So there's heart failure hospitalizations. That's what we hope to decrease. So let's say we decrease those. I want to make sure that nothing else has increased at the same time. So I want you to measure total hospitalizations and make sure they didn't go up. And similarly, when we look at heart failure quality of life, that's what I really want to make better. So but I also want to measure with the promise overall general quality of life to make sure that certainly it hasn't gotten worse, but that there's some trend that it's better. So I think one is really where we're putting our money in terms of the endpoint, but you need to check it in a broader context to make sure you're not having some unexpected effect or a lack of effect on the overall person.
But then it seems to me you're saying it should be total hospitalizations
No,
or total
I'm just saying
mortality. Well, what if heart
I'm saying
failure
you
mortality?
I'm saying you measure total
But
hospitalizations.
what if heart failure mortality goes down, but total mortality goes up?
Well, then I don't think I want to use that.
Well, then you are saying use total mortality.
No, I'm sorry, I'm not talking about, mortality is a hard
all
endpoint with
cause.
different issues. Certainly we would look at total mortality as well as CV, but I'm saying for hospitalizations and for quality of life, we're targeting the disease-specific ones, but at the same time, we just want to monitor the overall quality and overall hospitalizations to make sure that there isn't a signal in the different direction.
Although I still, it seems that you're saying, but if there was a signal in a different direction for hospitalizations, then you wouldn't be interested in it.
Well, I think we would need to look at it very carefully because that would be a difficult decision. Okay. I think none of us can anticipate all the possible results we could get. But if they went in the same direction, for instance, you'd be much more comfortable taking the heart failure hospitalizations than if they went in a different direction.
Dr.
It's almost
Yancey.
like powering questions statistically rather than anything else.
I'm not powering it in the total, but
That's
I want
you're
to
powering
see
on
the
a
trend.
disease specific, but you make sure the trends
Exactly.
are towards better, even though you're underpowered for a
Exactly. Yeah, you said it much better than I did. Yeah, that's good.
So I'd like to go back to kind of the basic premise of taking care of these patients. There really are only two goals. We want our patients to feel better, and we'd like to change the natural history of their disease. Some would call it the life course. Those are the only two goals that matter here. And we're saying, can we be confident that a new technology helps a patient absent data on mortality per se? We can certainly incorporate mortality and totality of hospitalizations and a safety dynamic, but what we really want to know is that there is concordance of whether it's quality of life, functional capacity, or some other metric that we're talking about. But the one important consideration that I think is necessary to emphasize is that not all heart failure is the same, and not every group of patients experiences heart failure in the same way. Heart failure with preserved ejection fraction is a very different animal than heart failure with reduced ejection fraction. We shouldn't conflate those representations of heart failure. So it is more awkward and more painful for us to think that way, but it's necessary because we have to be able to ensure that what we're recommending for one cohort of patients doesn't disadvantage another, even if the disadvantage is nuisance because it's of no benefit or no harm. So we should be very specific about what kind of heart failure we're dealing with. I personally take exception to the idea that we can't use biomarkers in some dynamic where we're talking about surrogacy. There's quite a bit of data. No, there's not ever been a patient that comes in and cares about their BNP, but there's not a patient that comes in that feels well that has a BNP that's 10 times normal. And so there is information to be had there. But for HFpEF, I have much less confidence that the BNP is predictive. So that's one example where there's a digression of a potential surrogate that we have to consider. So this is really a more complex conversation when we're talking about heart failure. We really should be very careful.
Thank you. Dr. Fish, then Dr. Salih.
Just thinking about the issue of comorbidities and the statement we're trying to help people feel better and change the natural history of their disease. I totally agree with that, but it shifts depending on which disease you think you're trying to modify, right? So, one man's junk meds is another man's disease-modifying agents. And I was sort of imagining that reference to junk meds as imagining a patient showing up in the hospital who's dehydrated, haven't moved their bowels, and has an exacerbation of their bipolar disorder. The heart failure we've succeeded at. So it becomes really complicated. All these patients have multimorbidity, and that really confounds what we're up to here.
Well, wouldn't that be the advantage of having a general quality of life measure to go along with a disease-specific quality of life measure? Because then those things would necessarily have to track in the same direction in order for us to have the right confidence about the intervention.
Marcel?
So, in terms of, I think, the difference between heart failure hospitalizations and all-cause hospitalizations, I think there is certainly a big issue of misclassification also. So I know a lot of the trials do this very well, but it doesn't mean that it will always be done well. And so I think I agree with the comment that, you want to be specific and look at heart failure hospitalizations, and it certainly, I think, is a very important and meaningful outcome. But yes, I wouldn't want to miss that it was really just shifting. And also the last commenter's point applies in the hospital as well. What exactly caused the hospitalization? Sometimes it's hard to tell.
Misclassification of outcomes?
Yeah. Because if you have heart failure hospitalization as your outcome, then, how exactly you classify it as heart failure is very important.
And actually, can you comment, why were you concerned that there was a disconnect between what patients want and what CMS, if that was your question earlier? I wasn't sure I followed.
Well, no, I guess I'm not entirely sure how CMS makes coverage decisions about devices, being more from the drug world. Maybe I just don't know. I don't know. Is there, is your coverage including bundled payments for all of the outcomes that happen in those first 30 days or in the first 6 months? Or I feel like there's so much beyond just talking about what specific outcomes we're talking about in the trials that are largely done by industry for FDA.
So, Rita, if you don't mind, I can add to this.
Sure.
I've never
ahead, Dr.
had a
Yossi.
patient come in and give me any conversation about their 30-day hospitalization rates. Not a single time. But that is important in our global healthcare system, and we are sensitive to that. And there's nothing physiologic about 30 days. So patients just simply want to feel better. And if that means coming in the hospital at whatever time point it is, then they want that to happen. So I think there are some different, I won't say a disconnect, but there are nuances here that we have to respect.
Thanks, Clyde. Joe, did you want to make any comment?
Just to, I guess, to the prior comment. So typically our considerations in our national coverage determinations are focused on fee-for-service, the fee-for-service system still. So typically does not include alternative payment mechanisms or models.
Like bundled payment being one of those
Yeah.
alternative payments,
Yeah.
although.
For now.
Right.
Right. Dr. Zuckerman? Diana?
Sure. Yeah, I just wanted to say about the hospitalizations, I mean, I think we can all agree that patients don't want to be hospitalized, and that's a good outcome measure to look at. But again, what we've said is there's so many things that influence it. It's not just the subjectivity of whether the physician decides it's a good idea. It's the decision. I mean, I personally know several patients who were told you have to go back in the hospital for another procedure, and they said, I want to die at home. And sometimes they don't die at home, but that's what they're told, and they would rather die at home. So you've got patient choices that are made, you have physician choices, and you have what you've talked about, which I would call quality of care alternatives. I think that's a wonderful thing if they don't have to go in the hospital and their doctors will take care of them in some other way. And even if the motivation sometimes is less than pure, I don't care, if the patient is going to benefit in that way. But so again, how do we measure hospitalization as an outcome, which I think we all think is important, and deal with the fact that there are so many reasons for it that have nothing to do with how well the patient's doing? It's a question. I don't know the answer.
Dr. Swain, did you want to comment?
Yeah, I think the original discussion about the FDA trials, I guess for CMS it's necessary but not sufficient. And then you need more data, which I think we've determined that you have a hard time getting the correct data or the real data. You're depending on kind of surrogates. But when we look at the FDA's expedited review that's been quoted on several sets of the slides, you have a BNP type agent, which the question is whether that would stand alone. Then you have a functional, and we've discussed some of the limitations, especially since mostly it's 6-minute walk. It's like pulling teeth to get people to do cardiopulmonary exercise testing. And then you have a QOL, a patient-reported outcome. And again, the problem is you're generally testing an invasive, new, great device versus a very often optimal medical therapy, which the patient views as nothing new. And so that's an automatic win on QOL. I can tell you from the placebo effect, it's an automatic win. And the important thing is that on all these composites is that you show a trend. And the definition of trend is certainly different. One of the FDA statisticians said, his definition is P less than 0.15. So you've now got Bayesian models looking at mortality, and that helps. But the basic problem you come up with is you have the 3 independent endpoints that have to be approved that perhaps all have different issues, but being a real surrogate versus QOL, which is an automatic win. So I think it's a hugely difficult problem for CMS to take an expedited approved device and then say, is it reasonable and necessary? Making that jump is almost impossible because you can't get real data. You need the actual post-market study data that's somewhat controlled, not TVT registries because they're not audited. It's a huge problem with TVT registries or any of the popular registries. So,
what are you thinking
Okay,
of?
so
What are you
Julie,
alluding to with
you
the
got
problems?
the FDA paradigm almost 100% correct, except for one thing. Step 1 is presentation of the data to FDA through the EAP pathway with 3 or whatever concordant intermediate endpoints in a Bayesian predictive model for mortality and heart failure reduction. But for presentation to CMS, there's a part 2, which is continuation of the randomized trial to show with more conventional statistical testing that reduction in heart failure, hospitalizations, and mortality, similar to what you're suggesting. So there's no real attempt to change the evidentiary level that CMS has seen for Class 3B devices for the last 10 years. In fact, compared to what was done in the CRT era, as mentioned on one slide, this is actually an increase in rigor for the reasons that you mentioned. But it will take a total commitment of the investigator and industry community to make this seamless process work.
But an increase in rigor from what used to be done, it's kind of like saying I'm the tallest member of my family. That may well be true, but an increase in rigor from previously, which is not rigorous at all, to something now that is better than that, I think we ought to aim for a whole lot better than that.
Right. It's I think we're getting back to sort of whether post-marketing actually occurs, whether the data gets released and is publicly available to clinicians as well as to patients, and whether coverage changes on the basis of post-marketing. The registry, and I don't know what you're alluding to, but for example, the ICD registry, we've gotten a lot of data collected, mostly in hospital, but coverage hasn't changed, based on all of that data. We're not, and that's kind of, if you want to make post-marketing work, it has to be an iterative process, I believe, where we're, continuing to look. And I think some TVT has been used to expand some indications for TAVR. I haven't seen otherwise a lot of data on how it's guided or changed coverage. And Julie, I wasn't sure, you had another comment, but you had alluded to problems with the TVT registry in your last comment, and I didn't know if you wanted to.
Well, single-arm
elucidate that.
registries that aren't monitored, it's a problem of entering data, and I can't give you exact examples, but I can tell you, I just question some of the data that goes in the TVT registry, how much gets done, and if you don't audit, if you don't have the threat of auditing a significant proportion, then it's a problem with data.
Okay, so perhaps Drs. Chin or Canos would like to comment on this specific item, because we haven't got into the post-market phase of this device development process, but mention has been made to the TVT registry as an appropriate model. And while it's recognized that all the problems initially that Drs. Redberg and Swain pointed out have been acknowledged in the TVT, to the betterment of all parties, CMS has been very carefully monitoring data quality in that registry, including the KCCQ acquisition development, and to the betterment of everyone, it's improved substantially. Do you want to comment, Joe or Dan?
Sure, and I think that's, we've been working closely with that registry to really try to improve the data, that we actually are seeing. So I think with really the post-market studies and what type of studies we can actually require, I think that's a different question than perhaps what we're actually trying to look at today. Because obviously there are situations with really what type of studies that CMS would like to see, and actually what type of studies that we can require, and also with the changes in pre and post market. So I think if we can assume like an ideal state with the approval process, I think looking at what type of and then coming to us and to CMS for a decision, really what type of outcomes by themselves then would be, aside with all the, I think, the concerns that were raised, I think that's given and perhaps not something to address today.
Joe, can you comment how complete the quality of life data is in TVT?
I think we've looked at it. I don't have the number offhand, but I believe since we've actually looked at it, it's actually gotten much better.
Is it like Julie being tall?
Dr. Carroll may be able to comment, but it's been a significant prime directive of all parties involved over the last 2 years. And that data can be made available.
But not right now.
I haven't memorized it, I'm sorry. Perhaps Dr. Carroll, if he's still here, can comment.
This is Swain, but as Dr. Pena pointed out, it's who collects the QOL. Is me as a surgeon saying, your heart operation went great, you feel great, don't you? Versus someone more independent. And that's a huge issue. So you may get a lot of data, but again, it's hard to tell what it means.
Yes, go ahead, John.
So there's some false impressions being given. Number one, I think you know it's John Carroll, the STS data, and it's audited. The same independent organization does audit TVT registry, number one. Number two, I don't sit with my patients and say, this is how to fill out your KCCQ. It's done independently without anyone present to prompt the patient, so it's really quite independent. Thirdly, the data completeness is really in the 90 percentile range when you look at in-hospital and 30-day, and that's as far as STS goes. We are, in addition, getting one-year data, and the KCCQ completeness has gone from 30 to 75% at 1 year, because we've had 500 sites opening up, doing something that's never been asked before in all routine clinical care to gather this kind of data. So it's really improving rapidly, and I just wanted to clear up those truths.
Glad to hear that it is improving. I would say that it would be easier for all of us if it was publicly available and we wouldn't be having this discussion, because then we'd all be able to look at it. I go on the TVT website, I can't look at any data there.
Well, every year there's a publication giving an update on
That's
all these things.
That's not publicly available, but thanks.
I just wanted to add, I mean, in addition to what you had said, I think the first presentation we had from Dr. Pena, she said, what makes me happy and what makes my patient happy? It makes my patient happy when I tell my patient, you know, the procedure went really well, and look at all these good things that are happening. So it isn't necessarily any kind of effort to have an impact on the outcome of a study. That's just the nature of the interaction, it seems to me, between the doctor and the patient, that when the patient seems to be doing well and the doctor is telling the patient they're doing well, then everybody feels good.
Dr. Siegel.
I would like someone to talk more about the blinding question that was started a little bit before lunch, and whether the trials need to be blinded, since that's one of our questions. And these trials really they don't have sham controls, right? Well,
Correct.
you kind of could put a catheter in and just leave it there. I don't have anything to say on the topic.
I would say, I mean, when I reviewed with colleagues the data on pre-market approvals to the high-risk devices, only 10% were blinded. And I don't think things have changed much. It's a big issue in device trials, because as Dr. Swain can tell you, or Dr. Siddiqui, and any of our surgeons, you know, when you do procedures or implantations, you do the procedure, people have a lot invested in it, and they tend to feel better.
Absolutely. I wanted to add to this. And there's a disconnect that we also have seen here about 6-month outcomes for quality of life assessment. If we know that there's such a strong placebo effect after surgery or after intervention with a device, how can we even live with 6 months quality of life measurement? Because again, a 6-month quality of life measurement can be strongly still affected by that initial strong effect of the intervention. Yeah, it's documented that there's early strong effect after surgery of improvement, right? So I think we do need to have much longer follow-up for endpoints that are prone to this placebo effect. So that's one point I wanted to make. The second point I wanted to make, and maybe Lynn, Dr. Stevenson can answer this, because you've been commenting, I was reading the CardioMEMS discussion at the panel, and you commented about something which was about package deal, physician plus technology evaluation, and in a context of it's not possible really to separate from each other when we have this remote monitoring technology kicking in and there's this placebo effect with it, but it's really not possible to separate it from monitoring because technology is transformational. It changes the way we handle the care. How do we even handle that, say this is placebo effect? So it's like, again, another side now from the more than 6-month quality of life measurement to the fact that there's some transformational technologies that change the way physicians would care for patients, and it's irreversible if it gets adopted. So essentially there might be an improvement because we pay more attention and physicians take advantage of this placebo effect. Because that might be a good thing sometimes too. I mean, if that's what it takes for us to have the placebo effect, maybe if it's not expensive and breaks our banks, maybe it's a good thing.
Okay, I just want to remind everyone we are going to be voting in the next few minutes, so we should just focus in particular if there's issues related to the voting questions that you want to resolve. Dr. Stevenson.
I just wanted to answer the blinding question, a couple of things. Number one, if you have something where to do a sham procedure is really high risk, obviously we're not going to blind. And those are the procedures in which I agree totally we wouldn't want 6-month outcomes because you want time to get over the stresses and the potential side effects as well of the surgery, so you'd want a longer time interval. I do think that by and large we should aim to blind in most cases. However, if the intervention itself is actually a strategy that involves patient empowerment, which we all know is going to be increasingly important, there's no way to blind a study where the patient is involved in his own care and tell him, you're going to be making decisions on data that may be completely fabricated. You can't really do that. So if you're testing a strategy that includes the patient's empowerment, I don't think it's possible to blind. But I think other than that and the high risk, I think we want to blind everything else.
Thank you. Although I would say, as I said earlier, even in high risk, I think it's, and I gave the example of neurosurgery, and I think Julie gave some other ones. I mean, those are high risk procedures, but to me, the danger of not blinding in a high risk procedure is that then you're assuming that a high risk procedure has benefit that it doesn't, and then we have really an ineffective high risk procedure that's no better than a sham procedure. So, I think that has been sort of gone through ethics approval, and people agree it's better to do a sham high-risk procedure than to make a false conclusion.
Well, I think it depends on the procedure. We're not putting in any VADs that don't pump, for instance.
Clyde.
We haven't made much comment about the issue of mitral insufficiency and subsequent repair. The way the question is worded needs clarification. The question is worded as if we're dealing with degenerative mitral valve disease because it says heart failure secondary to mitral regurgitation, which there's an evident database that informs what we should do and guidelines as well. I think the greater conundrum or the greater question is functional MR, where the MR is secondary, but it would matter how I vote depending on what the intent of the question is. If we're talking about degenerative MR or functional MR, that may be too specific, but if you can help with that.
I think that's an important question. For Joe.
So I think it's been degenerative, and actually that's what we have typically focused on.
Because the trials that are being done now, just to take this one step further, are focusing on functional MR, because there's already an FDA-approved indication to intervene on degenerative disease.
Right. So I think as we've been seeing these type of devices being approved, then that would be actually a consideration for what we've actually have available right now, I think, have been, degenerative ones.
Okay, so Joe, you are correct. The FDA-approved device is for degenerative, but as Dr. Yancey is indicating, there's a whole slew of EAP devices coming down for functional MR with associated significant heart failure. So could this question be divided into two parts where one, you ask for the degenerative MR cases, and for the other, for functional MR with significant heart failure, something like that? I think that's what Dr. Yancey is suggesting.
Thanks, Dr. Zuckman. Dr. Yancey, that's fine.
Sure. So I think that's an option that's up to the panel.
Okay. And any,
I just have a point of
Dr.
clarif-
Berliner, I think you've had your card up for a while, sorry.
No, I just wanted to ask a question for 3C and 4C. It says composite standalone. Is it for question 3C and 4C? It says composite standalone. Is that composite or standalone?
That does seem like a typographical error.
Composite.
All QOL is composite. They have like 20 questions.
I think it means whether the standalone endpoint could be a composite or the standalone should be in the primary health outcome. That's how I interpreted it.
Dr. Redberg, as a point of procedure, as we go through each question, can we just clarify a little bit? Because some of the questions there's something kind of vague about, and rather than answering all the questions now, if we can go by each question one at a time and then clarify before we vote would be helpful.
We'll do that. I'm going to, well, let me see. Is there another? Dr. Siegel, did you have a question?
Sorry.
Okay. So Maria is going to give out the clickers, and we will start voting. And I'm happy to clarify. We did go over some of these on the call last week, but I don't think everyone could be on that call.
Also, would like to mention that when you vote, actually, there's an opportunity to explain. So I think if there are specific points you want to make about how you interpreted it or how you voted, there is an opportunity for that.
All right. While Maria is giving out the clickers, I am going to start to read the first question. And just to remind you, the voting scale is written there in your form. So if you have low confidence, you would vote a 1. If you have high confidence, you would vote a 5. And you can vote any integer in between. So the first question is, how confident are you that the following are standalone, meaningful primary health outcomes in research studies of heart failure treatment technologies? And I'll read them individually. A, heart failure hospitalization. Then we'll vote on heart failure hospitalization or heart failure hospitalization equivalent event, like outpatient intravenous therapy for heart failure. Or C, total hospitalizations. So obviously we'll take A, B, and C separately. So you can now vote on 1A. Yeah.
Assuming that we would have no mortality data. Is that right?
Right, and these questions are standalone. So you're saying you would accept this in lieu of mortality. This would be a standalone. You would not have mortality.
Well, I think we'd want to clarify that this is assuming safety and no reason for concern about mortality. I mean, so that there's no adverse trend.
How would you get that data without collecting it? How would you assume safety?
Do you have any clicker instructions, just so we make sure we're doing this part right? Press one button once.
One button, your last vote?
Yes, your last one. And it will be posted up there, so when everything...
You can change it.
What was the response to Dr. Stevenson's question?
My understanding, it's standalone. You're
Right.
voting on this as an endpoint by itself. So
And also-
you cannot assume you would have other data.
Also,
This would be
Well,
it.
you'll know who's dead.
So I think that
So,
we are looking at these devices in the post market. So I think there is an assumption of assurance of safety and effectiveness in that situation.
So that's helpful.
Well, this is Swain, is it helpful? So are we considering this along with mortality or not? It says standalone. Rita has one explanation. You're saying we can assume that mortality is being measured, so it's not a standalone.
No, I didn't say. I guess we can assume that it's being measured now. I think I was just trying to respond to Dr. Swain's comment or question earlier that the scenario. So I think in terms of whether there is the initial evidence on safety and effectiveness, and I think that is what we actually would see with a post marketing approval.
But,
Can I change this?
but being safe and effective doesn't mean that nobody dies from it.
Joe, can
Right,
I make an assumption that if a drug or device here had a clear-cut mortality benefit, we wouldn't be really voting on hospitalization? So this would be a new device or drug brought to CMS with just for the hypothetical, a neutral mortality benefit, but there's a hospialization signal
Alan, we would not know the mortality.
that we don't know,
period.
so we should have no
Right.
assumption.
No
Right.
assumption.
No assumption.
You're saying, would you accept data short of a mortality benefit? And this is the question.
Instead of mortality.
Instead of, right. So in that situation where we're actually seeing these, if you can sort of imagine the scenario that we're being asked to review these new technologies.
but if a lot of people died, then they wouldn't get hospitalized for reasons that we're talking about. So we're assuming that there's no reason to be concerned that there's a competing outcome between death and hospitalization. We'll just assume that.
No, you don't assume.
No, you could have a low hospitalization because a lot of people died. You wouldn't know that
I would
in
know
this
that
question.
they died. If I know that
Pardon?
they're hospital, but I would know that those people died.
How would you know?
Well, if I
It's
know
not-
they got hospitalized, I would know that they died. I mean,
So I think that's a factor in how you actually vote. And I think you can have an option to say, I voted in that manner.
So this is nearly nonsensical because you would at least need to have a safety awareness. You wouldn't necessarily need mortality sufficiently valid for an endpoint, but you would have to have some safety awareness.
What do you
Otherwise,
think?
the
What is
regulatory
safety awareness? How would you define that?
Whether it's in a clinical trial, a phase 2 trial, observational data, there'd have to be something that reassures that there's not a signal of harm. I mean,
But
this is
what
just
would
being
that
proven.
be?
The things that I just identified. Some predicate data set that indicates that there's not a signal of harm. It may not be a definitive advantage on mortality, but says that it's not a signal of harm.
Daniel?
Daniel Conyo's Coverage Analysis Group. So completely agree with the assessment of the question. It's asking as far as a meaningful primary health outcome, not in an imaginary world where we're blind to whether there's mortality or not. So if a sponsor has come in with a study that's primarily driven by heart failure hospitalizations as the meaningful health outcome primary, there could be secondary analysis that look at mortality, look at harms. So we're not trying to create this contrived environment. We're seeing studies where heart failure hospitalizations are the drivers of the study. We look at mortality as other endpoints and do that as another consideration. So capturing harms as secondary endpoints, but if they were to come in with a study, and again, there's plenty of study designs you've seen with endless secondary endpoints or tertiary endpoints that capture these assurances. But if heart failure hospitalization was the primary driver of the study for sample size and for the meaningful health outcome, that's how the question should be viewed.
So, Daniel, is it fair to say you're talking about a study that would be powered on hospitalizations? You might collect mortality,
That's exactly
but it would not be sufficient to make any conclusion.
Exactly. Your scientific conclusions based upon that primary driver of heart failure hospitalizations. Is that it?
Secondary analysis, not a primary analysis?
Yeah, I wouldn't. The mortality data could be captured in these as part of a secondary, for the secondary analysis as a composite or otherwise. But when you view heart failure hospitalization as a primary driver for the study, sample size, and the hypothesis being tested, It was the nature of the question.
So the Swain, so that we may want to vote again, since you've already captured
We
votes, since
haven't
it's
voted.
totally different than what we,
We haven't voted yet.
what I thought. Okay. So it's more like the FDA thing where you have a primary and then you have a trend. And so you would have mortality data. So it's, I view it as a composite of mortality, even though that's not powered, and your answer of one of these.
No, it's a primary endpoint to be powered on hospitalizations.
And there's a discussion
But
point.
you have all the mortality data is what he's saying.
There's a discussion part about composites as a sub.
Right, but
Part under
but
this.
the voting question, Julie, to be clear, is it would be a primary endpoint of heart failure hospitalizations. That's
But you
it.
would have all of the mortality data is what,
You might have that, it would not be powered for that, and you might not have sufficient power to make any conclusion.
For the purpose of argument, could we say that we're voting on a trial in which the mortality is equal in both arms, but there's a significant difference in
I don't think we can
hospitalization?
say
Because
that.
that's,
No, we
that's what
can't.
the question is.
But can we say mortality data is available? That's pretty easy, right? We can say mortality data is
I
available.
think you can say mortality
I mean-
data is available, but you can't say that it would give you any
Yes, we don't
meaningful
care what the
information
results are,
because it
right.
wasn't powered for mortality.
Agreed,
You
but
may
at least
see a
it's
gets back to
available.
signal
my
one way or
original
another, but you're not going to know.
concern that composite endpoints that are driven by one feature is not the solution either.
Okay,
We need
I
to
want to stick to
capture
the
all
voting
that.
question, and it's primary.
Is, so Rita, is a reasonable interpretation, can you hear me now?
Yes,
Yeah,
yes.
is this that the, for heart failure, the assumption is that the mortality is sufficiently stable, that heart failure is the signal? I mean, that's where, what we're saying, that's where we are?
No, there is no assumption on mortality. Okay, the question is, can a primary endpoint be heart failure hospitalizations as a standalone? That's the question. Mortality data may be collected, but it will not be what you're voting on, and you are not likely not be powered because it's not going to be powered for mortality. You won't have a signal one way or the other.
How confident are you in that
Okay.
signal?
So let's start the vote because we are now. Did you have a question?
We've already done 1A, right? We've already.
This is 1A.
7 of 9. 2 more people need to vote.
Do it again.
I already read the question.
I don't think you'll count,
Yeah.
We just need one more person. Could everybody? There we go.
Okay, the vote for 1A was 2.44. Maria, do you want to finish the B and C now and then talk, or talk after each one?
We need everyone to vote, say their vote. For,
Okay, for each one,
Yes.
so individually. Okay, so we'll go down the line, and everyone can say their vote in one, I don't vote.
Oh.
One sentence on
Hirsch,
why you voted.
3, my level of confidence is intermediate because there are physician and patient things that can game the outcome by itself. It's not adequate, in my opinion.
Cruz, 3 as well, similar reasons.
Fish, 2. Really similar reason, different number.
Kobolars, 4. I think hospitalization would be a good primary endpoint.
Salive, I gave it a 3. There's definitely problems that were alluded to, but there's also, I think, geographic differences in hospitalization that can play an effect, and also international ones, where this has been seen in the global device studies, that there may be differences by country.
Art Sidrak and I voted 3 with the assumption that mortality data is available. I know it's not powered, but at least it's available for weighing benefits and harms, even if it's a trend. So that gives me a little bit more reassurance with that assumption. We agreed it's manipulable, it's open to physician influence, patient influence, but I'm also still unconvinced about this role of new technology transforming our healthcare and how more effects are possible through that placebo effect, and whether it's a good thing or bad thing, and how we can take advantage of that. So I think I'd like to, I'm comfortable with 3.
It's Siegel, 2. I think it's a patient-relevant outcome, but I think it's too hard to standardize for trials based on what was discussed.
1, because it said standalone, and it does not guarantee that mortality data is available.
Zuckerman, I said 1, not just because of the mortality issue, which is important, but for all the other reasons we talked about, subjectivity and patient choices and geography now. And I'm even wondering, does this count people go to nursing homes? Are they hospitalized or not hospitalized? So there's just so many other things that can happen to people that would affect it.
Eileen Sheesh, I said 3 because that we're including the whole population, and it only is a standalone for patients with low mortality risk, and then hospitalization matters a lot, or people who are going to die, and then hospitalization matters a lot. So that really takes a chunk of patients, 3, but the people in the middle it does not apply to.
Lynn Stevenson, first of all, you have to have mortality, so it's not a competing outcome. I voted 4 for the first one, 4 for the second, assuming there's a hierarchy so that you get more points for having a
We're only doing
hospitalization.
the first one now, Lynn.
First
You're
one's
ahead of us.
4.
Okay, that's it. That's it. We're going to come back.
Oh, I'm sorry.
You can only vote 1 at a time.
But
We'll
I am
come back to
assuming
you for that
I'm
one.
assuming you know mortality, because otherwise it makes no sense.
Okay, thank you.
Adi Renbaum, I voted a 3 for mainly reasons that have already been stated.
Elise Berliner, I voted a 2. I think it's really, really important, but in conjunction with other things.
So I was really conflicted on this, but I think in a low mortality, assuming that it's a low mortality cohort, that hospitalization would be important. I voted a 3.
We didn't get your vote. Can you say your vote for us?
I'm sorry, I voted 3.
Thank you.
So I voted 5. And I voted 5 because we have to respect the natural history of a hospitalization. 1 year after hospitalization, the risk of death is 25%. That's been consistent in all the trials. A therapy that lowers the risk of hospitalization with a neutral impact on mortality would be very important.
Bram Zuckerman, I voted 4. I think even with all the problematic issues mentioned, it's still an extremely important endpoint.
Okay, now that you're all experts in voting, we're going to vote on Part B of the same question. So it's how confident are you that the following are standalone meaningful primary health outcomes in research studies of heart failure treatment technologies, but now you're voting on heart failure hospitalization or a hospitalization equivalent, like an outpatient intravenous therapy stay. Could start the music. Guys are pros now.
Getting good. One more.
Okay, so this was 2.78, and
To keep the discussion going, Hirsch, I gave it again a 3. It's actually a better outcome, combines the inpatient, outpatient settings, but I actually respect the other voting lower rates as well. 3.
Cruz, 4. This response added or captures a few more patients than just hospitalizations.
Fish, 3, upgraded from before where it was 2 because it's a little bit less biasable with the specifications of this one.
Kobelar's 4, being consistent with A, I think a good primary endpoint, would be preventing hospitalizations by whatever means.
So leave 3, I think it has the same issues as the last one.
I'm also consistently 3, Sidrakian. In fact, I really think that hospitalization should be categorical. It should be number of days. And as Dr. Stevenson commented on, counting these as 1 day or something, we need to come up with a good measure. And in addition to categorical endpoint, we should have something more meaningful amount of time being hospitalized.
See goal 3. I think it's better than the first in that it's an indicator that the patient needed some intensification.
Swain 1 again because of mortality issue, because I'm voting for what the question is written as, but also I think it's somewhat worse than hospitalizations. If it were with mortality, I would call it a 2 or a 3, but it can be gamed. We've seen that in a famous study done, and more importantly, the people evaluating the patient in an unblinded trial will try to keep them out of the hospital and by giving outpatient therapy, so it's unintentionally biased.
Zuckerman, I voted 1. I do think that maybe some of these other measures would be better than hospitalization, perhaps for a variety of reasons that hospitalization is so disliked by patients, among other things. But we didn't really talk about these other options. So.
Eileen, she's 3 for the same reason as the last vote.
Lynn Stevenson 4, again, assuming a hierarchy across the IV outpatient to the inpatient.
A D. Renbaum 4, I think it's an improvement over the last measure.
Elise Berliner 2, I think it's the word standalone. I think it's very important, but not as a standalone.
I voted a 3, and while I think it offers perhaps a more, it could be more powerful than just plain hospitalization, but it really lacks external validity. I think it lacks external validity. There are some pressures over what happens in a hospitalization. I don't know what all these other visits may mean.
I voted 3. We should recognize that there's no evidence base to support outpatient parenteral anything, including diuretics, and it's probably a signal of harm.
Bram Zuckerman, I voted 4. There are problematic issues, but still remains an important endpoint.
Okay, thank you all. And now the last is the same beginning of the question, but you're voting on total hospitalizations. Same scale.
We're waiting on 4 people.
Maybe everyone just vote again. Maybe you voted before the clickers were activated. One more. Okay. And this was a mean of 2.11, which is low or low intermediate confidence. So we have a discussion question, and only for part B, because the discussion question is only for health outcomes that had a greater than 2.5, so greater than intermediate confidence level. And so for part B, which was hospitalization or hospitalization equivalent,
Yeah, we don't want the explanation.
Individual responses.
I'm sorry, I'm getting ahead. Go down.
Well, I'll try to make this short. I downgraded this to 2. It's a complicated question because we really haven't talked about the noise of a positive or negative signal. But in the spirit of a heart failure outcome for a heart failure patient, I downgraded total hospitalizations. 2.
Cruz 2, total hospitalizations may not reflect just heart failure, but other reasons.
Fish 4, I thought total hospitalizations was a little bit of an upgrade because it's more robust to the patient experience.
Kobolars 3. I thought that, there are other reasons for hospitalizations, and I think focusing on, heart failure would be more of the primary endpoint that should be considered.
So leave to, I think the reasons were mentioned.
Sedrakian 2 as well. It introduces more noise. It can go both ways. It's important to measure that because if reduction in heart failure hospitalization might lead to some other hospitalization increase, then it's a problem. But we need to probably measure this if we're measuring the other two. But at the same time, it introduces a lot of noise for other reasons, hospitalization, surgery inclusive.
Siegel, 2. I think it's noisy as a primary outcome.
Swain 1, same reasons and noise.
Diana Zuckerman, 1, same reasons, but also I hadn't mentioned before, sometimes people are hospitalized because they don't have anybody to take care of them.
Elaine Sheesh, I wrote this as a 3. I have a problem with this as a primary endpoint, as a standalone, without heart failure hospitalizations. Even if you reduce it total, you're reimbursing for heart failure, and if it's not affecting heart failure hospitalizations, it should get credited to whatever disease you are affecting.
Interesting. I gave this a 5. I would have incredibly high confidence if you achieved this, because most heart failure patients are hospitalized with heart failure. I just think it would be foolish to power your trial because I don't think you'd get there. It's a high bar, though. I'd be very confident if I got there.
Adi Renbaum, 3.
Elise Berliner, 2, for all the same reasons.
I voted 2. I had some initial confusion about total hospitalizations, whether that was total heart failure hospitalizations, but if it's just a general, I stick with the 2.
I suppose I'm going to be the minority today, and I'm going with a 5. Because you have to recognize that if there's a strategy that is targeting heart failure, you have to be aware of changes in renal function, you have to be aware of falls, you have to be aware of syncope, you have to be aware of mental confusion, you have to be aware of complications from a procedure or a drug. I would agree that this is a very high bar. I'd be very confident if I saw this. And as well, nobody would collect total hospitalizations without also concomitantly collecting heart failure hospitalizations.
Hi, Bram Zuckerman, 3, problems with noise.
Thank you. Now we can have that discussion of just for the B, which again was hospitalization or hospitalization equivalent events like outpatient IV therapy. What would the appropriate length of follow-up post-heart failure intervention be for this outcome? Alan, did you want to throw out a number?
Well, we can start the discussion. We really haven't spent that much time on it. So for non-acute LVAD, shock patients, I think for many of us in cardiology, a 1-year period is fairly standard. Getting away with 6 months allows a short-term benefit in noise and a loss of expensive device or drug. Frankly, I usually advocate for longer. Relevant periods of time of 2 to 5 years, although again, I realize for sponsors it raises crazy costs. But 1 year is my usual minimum.
So 1 year. Yes, Doctor.
Look, I don't have it.
Oh, I thought you were commenting.
Michael Fish, I think it depends on the condition and the expected trajectory of illness, as well as the trajectory of adverse events and the magnitude of the rate of adverse events. So there's a lot of things that go into it. But I'd say, generally speaking, taking the whole pool of things, 1 year seems reasonable to me.
Does anyone? Julie?
I agree with 1 year for the sickest patients, but if you get down to NYHA 2s, I think longer than that, at least 2 years. FDA has a problem ever mandating anything longer than 2 years. I think that's still the case. But for the minimally symptomatic that's going to have a permanent device for chronic disease, it's got to be longer than 1 year and maybe longer than 2 years for some.
Dr. Zuckerman?
Yeah, I guess I would just ask, this is really a question, are you thinking are people thinking in terms of separately measuring inpatient and outpatient, as separate scores, or just combining all procedures. All so-called equivalent events.
It would be all heart failure hospitalization equivalent events plus heart failure hospitalizations.
Plus outpatient, including outpatient, yeah. So one score, for example.
Can I comment on competing risk issues here because of high risk of mortality? Just making sure that is taken into account in a time frame that is being measured. It's pretty high mortality risk within a year, and just need to comment about that we need to take into account the high chance of dying. One more comment. I'm not sure Dr. Stevenson's votes are being counted because she said she voted 5, but
Just the panel's votes get put up there, everyone's is non-voting members.
So
Okay,
I agree
think
with
we've
1
heard-
year, but I wanted to just make a short comment that I think for the coverage decision, you could do a year follow-up on this outcome, but you would want, as was said, I think lifetime actually follow-up for safety problems for some kind of novel device. So
Yes, certainly for an implanted device, that is in for a lifetime. A lifetime seems reasonable. There was a mention of composite, and that is actually what we're supposed to be discussing now, is the merits of composite outcomes, which include the combination of mortality, heart failure hospitalization, or heart failure equivalent events. So it kind of is what we were just talking about. What would you think of the merits of that composite outcome?
That's
Dr.
essentially
Stevenson.
what you're going to be measuring, whatever you call it, that's essentially what you're going to be measuring.
Right. That's what you would be measuring, is the composite outcome. It would seem to me, the issue would then be, what if mortality was up, but hospitalizations were down? So then the overall composite would look favorable, but the actual...
Right, but safety wouldn't.
Right.
So. And just for the record, there's very few heart failure interventions that we've thought about using in which quality and hospitalizations go in the right direction and people die. Usually, we don't have to make those sorts of decisions.
For endpoints,
Did someone, Dr. Devine Nickens, did you want to comment on composite outcomes? Your card is up, I think.
No, I don't, I think I can, concordance obviously is important, but otherwise it's
So I guess I've always viewed hospitalization as an event. And for events, when you're doing research, you count the number of events. You have to have statistical significance between groups. So it's time to event, and it goes back to Dr. Allen's comment about what stage of the disease. It's also New York Heart Class 2 versus 4. So I understand picking a time point for quality of life because you have to decide when you're going to do it. I understand it for functional capacity, but I don't understand it for hospitalization where you have to have an event.
Dr. Swain?
Well, I think, though, you can have multiple hospitalizations, and people pointed that out, that you
Yeah.
can have 4. And so then your time to event is not an analysis you can easily do with that.
Right.
And I agree also that this is a composite for censoring purposes also, that, they're not at risk once they die.
But we're creating one population of heart failure patients that range from well to sick. And so that's where it gets very complex.
So I think I've heard we need to note the severity of heart failure we're talking about. That would certainly affect the length of follow-up and how we look at it. And also that we're interested in a more continuous variable, not a time to event, because Dr. Stevenson suggested days of hospitalization. I think we've heard interest in how many hospitalizations, and that would give a richer data source. Dr. Swain?
Yeah, and I agree with Dr. Stevenson that we've got to get some sort of hierarchical figure out because you've got mortality. One thing, you may have mortality, you may have heart failure hospitalization, which I think is still defined as a calendar day, calendar night. Come in at 10 p.m., go out at 8 a.m., that's hospitalization. and the amount of invasiveness of the out-of-hospital intervention. So somehow one has to figure out a hierarchical approach to this.
Dr. Zuckerman?
Yeah, I agree with that hierarchical approach, and I don't know if this is part of the question, but, to the extent that you can statistically control for other variables that you know of, that might be relevant in terms of affecting why a person's hospitalized or not, I think that would be helpful.
Okay, that was excellent. We're going to go on to the second voting question, and it's a little different than what we've just been talking about because it's looking at different, sort of what you were interested in, different types of heart failure. And the question is, how confident are you that surrogate and intermediate endpoints are predictive of standalone, meaningful primary health outcomes? And I'm sorry, this didn't get moved. Let me rephrase that. How confident are you that surrogate and intermediate endpoints, such as reduction in mitral regurgitation, cardiac remodeling, ejection fraction, or biomarkers, are predictive of standalone, meaningful primary health outcomes in research studies of heart failure treatment technologies for heart failure with preserved ejection fraction? And again, the voting scale is the same. So the voting question is whether you think you have confidence in surrogate and intermediate outcomes for technologies for heart failure with preserved ejection fraction.
I would suggest that for the endpoints listed, I don't have any confidence for heart failure with preserved ejection fraction that these would work.
Ditto.
We need 2 more people to vote. Okay, this was a 1.56. And Alan, do you want to discuss your vote?
They've spoken for me. Hirsch won. There just hasn't been enough presented to give me any confidence. The outcomes are relevant to beneficiaries.
Cruz, 2, same reason.
Fish, 1, similar reasons.
Kobalars, 3. Saliv, 1.
Sedrakian, 2. We have never seen evidence about change in surrogate endpoints leading to change in standalone endpoints. That would decide it for me, not the correlation. There might be a lot of correlation. Vitamin deficiency is associated with birth defects, but not all birth defects can be prevented by giving vitamins to people, just like the epidemiological basic example that we know about.
Siegel, 2. We didn't hear much about the preserved ejection fraction group.
Swain, 1 for most of these, except for the amount of MR. For functional MR, that would be a 0, but you don't allow zeros.
Diana Zuckerman, 1 for the reasons everyone else gave.
Eileen Sheesh, 1.
Still 1.
Adi Renbaum, 2.
Elise Berliner, 1.
Patrice Nickens, 1.
Claude Yancey, 1.
Zuckerman, 2.
Okay, we're going to vote now on mitral regurgitation. And if you recall, Dr. Yancey suggested we split this into degenerative and functional, and so we're going to do that. So the first one, we're voting on degenerative mitral regurgitation. So the same, starting out about the surrogate and intermediate endpoints, but now do you think that they're meaningful primary health outcomes in clinical research studies for heart failure secondary to degenerative mitral regurgitation?
Can I just clarify the question? So you're saying, is a reduction in mitral regurgitation a good indication of how patients will do who were supposed to have complete treatment of their mitral regurgitation but still have mitral regurgitation? Is that right? So we're saying people who are ineffectively treated for mitral regurgitation.
The question is, as
matter?
a treatment for degenerative mitral regurgitation, do you consider reduction in mitral regurgitation a meaningful standalone primary health outcome?
Well, this is kind of gets back to does the therapy actually do what it's supposed to do, which is kind of sort of a tautology.
And let me, Swain, let me ask, when you say reduction, I guess there's a problem because 4 to a 3 is incomplete. You know, the guideline, AHA guidelines say mitral insufficiency is the disease.
Yeah.
But I guess if we could not talk about reduction, just measuring MR, amount of MR.
If you haven't gotten rid of
Good
it,
with that.
it's still going to be there.
No,
If you haven't gotten rid of the MR is still going to be
no, get rid of the MR.
there. No, but if you didn't get rid of it, it's still
Just,
Exactly.
so the question is written, just assume a reduction in mitral regurgitation. It wasn't quantitated.
One more.
Okay, and that score was 1.78. Dr. Hirsch?
A Hirsch 1 is a Swain 0. This is the holy grail of cardiovascular medicine and heart failure. We don't have evidence that this correlates, and you're right, it can't just be a reduction. You want to be abolishing it, which doesn't always happen. Next.
Cruz 2.
Fish 1.
Kobalars 2.
Salive 2.
Same to Sedrakian 2.
Siegel 4. I think I didn't understand the question that well.
Swain, a Hirsch 1.
Diana Zuckerman, 1.
Eileen Sheesh, 2.
1. Oh, I still don't understand. I'll send it to a different
Runbound
surgeon
2.
next time.
Berliner 1.
Patrice Nickens, 1.
I guess I'm not only a minority but an outlier now, but this is the basis upon which the technologies were approved to address degenerative disease, that they were able to reduce MR, able to affect reverse remodeling, able to lower the biochemical signal. So I don't want to be that far an outlier, but at least a 3.
Zuckerman 3 for the same reasons.
Come back
Okay.
for a comment?
Nope. Okay, the next is, remember we split mitral regurgitation. So now we're going to vote on functional mitral regurgitation. Exact same question, but functional, we just voted on degenerative. You can vote.
Rita, would it help to define functional MR for those members of the panel that aren't quite aware of the significance of that nomenclature? Or don't touch it?
Do you want to go ahead and do that, Clay?
It's easy enough to do. I mean, at least will save us
You think
some
that-
orientation.
Sure.
But in the setting of heart failure where the muscle is weak and dilated, the process of the muscle becoming weak and dilated makes the mitral valve less efficient. It fails to close correctly, and that leads to residual mitral insufficiency, which may be important. So the question on the table is whether or not addressing that kind of MR, which is less because the valve is problematic and more because the heart is misshapen and enlarged, leads to reasonable outcomes in heart failure. So that's why it's called functional. So it's a very different etiology than what we just addressed, which is where the valve itself is a primary disorder, as Dr. Swain just alluded to.
Where does it say that?
Okay, that's, I couldn't find it.
Okay, we need 3 more people to vote.
Oh.
Okay, that's a mean of 1.67. Alan?
Hirsch had 2. I was swayed by the discussion.
Cruz 1.
Fish 1.
Kobalars 3.
Salive 1.
Sedrakian 2.
Siegel 3.
Swain 1, unlike degenerative, which that is the disease.
Diana Zuckerman, 1.
Eileen Sheesh, 1.
And Stevenson 3, because it's a good thing to do, but I'm a little worried because we're not measuring whether you do something else that hurts the heart somewhere else.
Renbam 4, based on the explanation I just heard.
Berliner 1.
Patrice Nickens, 1.
Yancey, 2. We really need to have an evidence base that in principle this is a reasonable thing to do.
Zuckerman, 3.
Okay, and now the C, because we split B into 2. So C is the same stem, but the heart failure is now heart failure with reduced ejection fraction. So it should be D, okay. We'll change that to B, C, and D.
Can you clarify, can it be any one of those markers? I'm not convinced if I like one, but I don't like the other two. How do I vote?
Any of them.
So any one. So I vote my highest. Okay.
We need one more vote. We need one more vote. If everyone could hit their clicker one more time.
Can everyone please vote? We need one more person.
Yeah, just, it'll only count once.
I did, but I'll do it again. I was too fast.
Okay, and 2.33 would be fast.
Okay, so we've studied HFrEF a lot longer. There's certainly some surrogates that correlate with better outcomes. Oh, I'm sorry, 3. So with that, I have a higher level of confidence. I'd rather see this as part of a combined, a series of endpoints that are co-directional, so it's not a 4 or 5. 3.
Cruz, 2.
Fish, 3. Certainly an upgrade.
Kobolars, 3.
Salive, 2.
Sadrakian 2, but I'd like to change to 3. I was undecided all the time, so I'd like to change.
Siegel 4, the cardiac remodeling sounds good to me.
Swain 1 only because MR was in that. Otherwise, it would be 3 if you didn't have MR in it.
Diana Zuckerman 1, because I just didn't feel like we talked very much about these.
Eileen Sheesh, 3. I think it's a little nebulous as a question because the ejection fraction from a reduced could go to a normal. Remodeling can go from dilated to normal. So how much I value this is dependent on what our goals are and what, and I wouldn't, going back to Lynn's comment, not all of those were things that I valued.
I think 3, if it were a huge impact, maybe a 4, and it would be quite low if it was some sort of structural girdling that decreases the LV size. I wouldn't have much confidence in it.
Renbam 3.
Berliner 1.
Patrice Nickens, 3.
Yancey, 4. Every effective therapy for reduced ejection fraction heart failure either affects reverse remodeling or has a biomarker signal, so we can't ignore that.
Zuckerman, 4. I think the physiology would be shown here in important.
Okay, so all of the A, B, C, and D were all less than intermediate confidence, so we're going to move on to question 3, which is on quality of life measures. And this question is, how confident are you that quality of life measures, and the examples here are the Kansas City cardiomyopathy and Minnesota living with heart failure, A, are adequate measures which reflect the patient experience? And please go ahead and vote.
I have one question because several people, speakers and others have noted that the Kansas City questionnaire isn't really a quality of life measure. So we're just I wasn't really sure what to do with this question.
Do you want to consider that this
And
could include
also
any
that
quality of life measure?
and almost all the data we talked about
Yeah.
today was the Kansas City data and not the Minnesota data, so.
That is all true, but I think for voting, you can consider that any quality of life questionnaire, so the SF-36 or any EuroQual, any of the ones we did not really talk about as in detail, but any of those, because they're all quality of life. Did you vote?
I did.
The voting poll is open. Everyone can vote.
I'll show you each time.
We're missing one.
They do it too fast, it's not ready.
Just one more.
Everyone just click again in case yours didn't
There we go.
register. Okay. Okay. This was a 3.78. Alan?
Hirsch, I'm honored to go first and lead this again. So isn't it interesting in 2017 compared to 10 or 20 years ago that during the presentations, the patient-reported or quality of life outcomes are becoming so robust? But they're not perfect. There's places to go, ways of making sure they're better validated. But I voted with that a 4 because I'm impressed and it's what our patients are looking for.
A cruise 4 also that reflect what patients want.
Fish 4, and I interpreted this as patient-reported outcomes instead of quality of life and got it around the semantics, but 4 for similar reasons.
Kobolars, and I gave it a 4. I think it's the most sensitive and specific, measure for heart failure that we have.
Sleeve, I gave it a 5. I think it's here to stay.
Sidrakian 4, it's certainly important. We just need to decide what and how.
Siegel 5. I was impressed by the KCCQ discussion.
Swain 2 because of the placebo effect in invasive studies.
Diana Zuckerman, I gave it a 2. I probably would have given it higher if it was only the Kansas City, but the Minnesota I wasn't so sure of, and also, perhaps a whole nother issue of placebo effect and control group.
Eileen Sheesh, I gave it a 5. I think the patient's perspective is important. It also assumes the patient's alive.
I'm between a 4 and a 5. I guess I'll give it a 5.
Grandbound, 5.
Berliner, 4.
Patrice Nickens, 4.
Yancey, a 4. I think we can do better than the KCCQ, and we should aim for that. The promise measures, I think, are quite important.
Zuckerman 3, I think it's still difficult to tease out a possible placebo effect.
Okay. And now we're going to vote the Part B, so it's the same STEM, but now you're voting on should it be included as the standalone meaningful primary health outcomes in research studies. So again, this would be the primary outcome. The study would be powered on the quality of life measure. Okay, and this was a 2.89. Dr. Hirsch?
So I maintained as Hirsch a 4, but I found the question again to be a little confusing because should be included is different from should be. Included implies there's other variables because as a primary outcome alone, the placebo effect is profound, and we've all talked about that. And so you have to have co-directionally maintained physiologic, patient-reported, and ideally clinically relevant outcomes, but at the end of the day, it's a 4 for me.
Cruise 4, similar reasons.
Fish 3, I sort of started at a 5 at the concept of PROs and the patient's voice, but downgraded it for bias, placebo issues, practical realities with interpreting missing data, responsiveness of the measures to change under certain circumstances. So practical issues down to 3.
Kobolars, I gave it a 2 because I think there
are other measures that need to be captured in other tools.
So leave 4. I think it's useful in some selected settings quite profoundly, and I mean, sure, it has some limitations, but I think it can be used and should be used more in trials as a primary endpoint.
Sidrakian, this is 2 as opposed to the other one being 4 because this is standalone and powered for that. And we know there's a bias. We talked about that. In fact, the comments about previous question apply to this one more. This is where the bias kicks in as an outcome measure. So it's definitely a 2.
Is Siegel 3, maybe not in a pre-post study or an uncontrolled study, but if it were in a trial, a controlled trial, I would like it.
Swain, 1 if it weren't a blinded trial, 4 if it were a blinded trial like drugs.
Diana Zuckerman, yeah, I made it a 3, I guess in the same thing that you just said, that it has to be placebo-controlled as much as possible. To me, that's different from standalone. I think it's important enough to stand alone, but it has to be controlled.
3 for the same reason.
Yeah, 3 because it has to be in a favorable context.
4.
Berliner 3. I think there should be other things, not standalone, but if we did just have to pick one, I think having the patient-centered outcome be the primary one is the best we can do.
Patrice Nickens, I gave it a 1. I think I was very concerned about bias as a standalone. Perhaps there are ways to protect against that, and I do think that patient-reported outcomes are extremely important. I just think that the bias outweighs that benefit if it's a standalone.
Yancy, so I go with a 3, taking the Hirsch interpretation of the question, 1 if it's truly a standalone.
Zuckerman, 3 for the problematic issues already mentioned.
Okay, so we're up to part C, and Joe just reminded me that during the call last week when we discussed the questions, we did agree to strike the standalone. So I will read it's the same stem, and should be included as a composite, meaningful primary health outcome in research studies. So again, it's the same quality of life measures. Should they be included as a composite, meaningful primary health outcome in research studies? And you can vote. Okay, and the mean was 3.33. Dr. Hirsch?
I'll just make it simple. I gave it a 3, and I think the question is still rather undefined. A composite as quality of life composites or composite with other things that don't go along with it? I'm confused, therefore I'm 3.
4, I took it as a composite with other events.
Fish 2, also tortured by what composite means in this situation.
Kobelar's 4.
So leave 5. I wasn't that confused. I guess I didn't understand the question at all. But, but I think it can be used and as an endpoint in studies, yes.
Sidrakian 4, I would like to see that composite measure. Is that hospitalization, MI plus quality of life? How do you combine the 3? I'd like to see that measure.
Siegel 5.
Swain 2, I don't know how to combine them, and placebo effect.
Diana Zuckerman, I took a 1 because I think it should be a standalone looking at quality of life, and I don't think it should be combined with other things that just muddy the water, and then you still have to deal with placebo effect.
I said a 4, Silene Sheesh, because I think it matters from the perspective of the patient, but we need other endpoints. And so I share your concern of how do you combine them, but I think I would want the data for them. And so for the fact that I want it to be added to what is collected, I wrote it as a 4.
Yeah, I'm a 5 on this. I can accept some ambiguity, but I am interested in context.
Renbaum, I gave it a 4 for reasons Eileen just mentioned.
Berliner, I gave it a 4 also for the same reasons. I don't know how you would combine it as a composite, but it comes closest to the idea of what I think should be, which is to measure a bunch of different things, and quality of life, very important part of it.
Patrice Nickens, I did give this a 5. I'm not sure if I understood, but this is so important to include, but I do agree that it's measuring something different than hospitalization or some functional measure or objective measure. But I think that we should consider ways of including, as a part of primary consideration, patient outcome.
Okay, so now the last question is the exact same question we just did, except now we're going to be looking at functional assessment instead of quality of life measures. So how confident are you that functional assessment, like the 6-minute walk test or VO2 max, A, are adequate measures which reflect the patient experience? You can vote. Two more people need to vote. Please try to vote again.
No.
Ventilator threshold. Ventilatory threshold. Sounds like we're intubating people, Joe. Kind of cute.
Okay, so this is 3.22. Dr. Hirsch?
I couldn't help. With humor, it's not the ventilator threshold. We're not intubating. It's the ventilatory threshold in exercise test. I think I give it a 4 because working with 6-minute walks, VO2s, and ventilatory thresholds, they're actually quite reproducible. They do correlate well. And I want to remind people, we never have C-statistics of 0.9. Most of our tests are moderately correlative. This is as good as it gets.
Cruz 3.
Fish 3, and I sort of took it to mean that this is something generally useful, maybe not necessarily adequate to reflect the patient experience per se, so I gave it a 3. I was wavering between a 3 and a 4.
Kobolars, 3.
Saleve, 5. I think the 6-minute walk is kind of like real life, although kind of not. But it's, and the stats are good, I agree. So
Sidra, again, I put 3 because it says patient experience, and only 6-minute walk test reflects that. The other ones are not patient experience necessarily. That's why I'm voting 3.
Siegel, 4.
Swain, 3 for 6-minute walk, 4 for VO2, but I'm waiting for the Fitbit, a week's activity measured by a Fitbit.
Diana Zuckerman, 1. I did a 1 because my experience with looking at 6-minute walk is that it isn't really reflective of how the patient lives. It's reflective of their motivation to do the walk in a test. And the other 2, I really wasn't sure of either, so.
So I rated it pretty high. I rated it a 5. I think, especially for peak oxygen consumption, we have evidence, even in normal patients, that it predicts outcomes and how they do. So I felt that this was a very good.
I rated it a 4. I would rate the 6-minute walk slightly lower than the objective other 2 measurements. And I would emphasize that that's for functional capacity. The patient experience, for instance, you could have a therapy that makes them nauseous half the day and then disturbs their sleep, and they could still exercise. So this does not fully reflect the patient experience, but it's good for functional capacity.
Renbaum, 4.
Berliner, 3.
Nickens, 4.
Yancey, a 3. I would agree that these measures are not quite as precise and don't necessarily track with how the patient does.
Zuckerman, 4, even with the above, an important endpoint.
Okay, and now we're going to vote the same stem, but the question, and we have modified it in response to the feedback from the earlier question to take out included, so I will read it. Should be that the functional assessments should be the standalone, meaningful primary health outcomes in research studies. And you can vote. One more.
If everyone could just vote one more time. All right, there we go. I'm sorry.
Okay, so this was a 2.44. Dr. Hirsch?
Hirsch, this may surprise you. I could have gone 2 or 4. I downgraded to 2 because I'm trying to wear my CMS hat, not my FDA hat. I'm looking for, a drug or device effect, and I think these are very reliable outcomes. I give this a 4 or 5, but I'm thinking this from a beneficiary point of view, where if this were all I were doing and offering the patient would shrug. Might even be a -1, but I gave it a 2.
Cruz, 3.
Fish, 1. You take a useful measure, but really overreach with what we're trying to do in standalone role.
Kovalars, 3, because I think a lot of it depends on the population.
Sleeve, 4.
Sidrakian 2, and again, same logic. Anything that is standalone needs to change in that standalone measure should also correlate, lead to change in the main endpoints that we talked about, mortality, hospitalization. So by themselves, they cannot be unless there's evidence that change in these scores leads to change in a meaningful endpoint. So it's 2.
Siegel, 3.
Swain, 3.
Zuckerman, 1. I just think it isn't very meaningful compared to a lot of other things.
Eileen Sheesh, 2.
Lynn Stevenson, 3. It depends what you're testing. If you're testing some sort of exercise training, I would make it a 5. If you're testing some sort of a drug that's supposed to improve cardiac function, then I would probably leave it at a 3.
Renbaum, 3.
Berliner, 1.
Patrice Nickens, 2.
Yancey, a 1. I would remind everybody that the predicate for this was a CRT where it was approved for about a 25-meter increase in the 6-minute walk as the only outcome. So we should keep that in mind.
Zuckerman, 3. Just for the record, CRT first approval was based on the Miracle trial where all 3 endpoints were positive.
Okay, and for the last part of this question, it is the same stem, and now it should be included as a composite, meaningful primary health outcome in research studies. Let's see if everyone can vote. Okay, so we have a 2.89. Dr. Hirsch?
Well, it's interesting. Composite to me is a beautiful thing. It's the triple crown where everything aligns the right direction. So this for me is a 4. I want function. I want patient-reported outcomes. I want hospitalization, survival. So I ranked it up. I'm in a minority.
Cruz, 4. I think this outcome and association, for instance, with quality of life, probably give it a whole lot more meaning.
Fish, 2. And again, if you consider it composite as being one amongst other things that you should look at to make useful interpretation of the research, then I would upgrade it substantially. I think that's really a great use of that test. But I keep imagining it as literally being combined with other things and scored where you have to interpret the whole composite at once in some confusing way that doesn't make sense. And I couldn't explain it to my grandmother. So that made it a 2 to me.
Kobelar's 3.
Saliv 2.
Sedrakian, I put 4, and I again took out the standalone part, and I looked at it as composite, similar to quality of life. So in that context, I voted 4.
Siegel, 3. I almost went 4.
Swain 3, and again, I agree that it depends on what you're looking at on those studies. So it could be a 2, could be a 4, but 3 looks reasonable.
Diana Zuckerman, I did a 1 just because, again, I didn't think it's all that meaningful, and I'm not sure combining it with a lot of other things makes it more meaningful. But since we didn't say what we'd combine it with, I really have no idea, but that means I'm not very confident.
Eileen Sheesh, I made it a 4. I didn't make it a 5 because not everybody can start with walking, and I thought of myself, I wish that I could dunk basketballs, yet if you make me taller, I probably still can't do it. So I don't, some of my patients who can't walk because of arthritis would probably still want to participate in studies, and that's kind of why I downgraded it from a 5 to a 4.
A 4, I think it's very important, but not standalone.
Renbaum, 4.
Berliner, I voted 1 because I'm still wondering if these tests are overlapping with something like the KCCQ, and the KCCQ seems more patient-centered. So are you double counting if you put them both in a composite outcome? So if I had to pick, I would, based on what I heard, I would pick the KCCQ.
Patrice Nickens, 2.
Yancey 4. I think this is very important because if we're talking about a new endpoint for which we would reimburse a new technology, having something like a functional assessment and a quality of life tool that are going in the same direction would be very reassuring. And so I think because it's part of a composite, it is at least a 4, if not more.
Zuckerman 4.
So I think we've had a really rich discussion. We've finished the voting questions. As you can see, there are several more questions for discussion, and I'm just going to highlight because I think we've covered a lot of what's in there already, but what we could have a little more discussion on is there's a specific, we talked about how long follow-up should be for the surrogate outcomes, but we didn't talk about it for patient-reported measurements. And we had said kind of 1 year or longer, depending on the severity of heart failure. Would you think the same for patient-reported measurements, or does anyone think it should be longer or shorter?
Can I comment like an example in joint replacement when FDA in fact requires quality of life measurements at 6 months, 2 years, 5 years, 10 years? It goes way longer time period. I mean, I'm not saying it's whether it's the possible in real world or not, but certainly recognizing this issue of subjectivity, possible bias related to placebo effect. I really think we need to think about longer-term quality of life measures to have a good picture and separate the effect of, as much as we can, placebo effect from sustained quality of life benefits.
And I would, Saliv, I would just say you need kind of a natural history study then, or a cohort study in parallel with that, because I think interpreting such data from just people who got implanted with X is, difficult. So I would, I think, and I agree that longer term, such a study of heart failure patients would be very interesting to examine.
But you're saying it's important to have a control group or
some sort.
Some comparison group, right? And of course, that's the issue, I think, with a lot of the registries is it's already assumed there's, in my opinion, that there's been a randomized controlled trial that showed a benefit over alternatives, and then now we're just looking at more details
But I
and
think
larger
even in terms of
populations.
communicating this to the patients, if you know, interpreting those results is very challenging if you don't know kind of a group of some sort of cohort that is followed over time. You know, even with the, you know, the vagaries of technology changing over time.
And that does kind of lead us into another question was how best to capture patient preferences. And we, again, have had some discussion, but if anyone has more suggestions on that.
Well, I brought up the idea earlier that our randomized trials, well done with fantastic nursing support in, usually downtown settings with not diverse populations, cannot reflect the full real world of what America is and will be. So the idea of actually expanding these to real world settings, which is difficult because we don't reimburse for it and we're working as fast as we possibly can, would seem to be important for a longer period of time, at least from my perspective. And I'm thinking Medicare beneficiaries deserve that confidence regardless of their background in non-inclusion in trials, including women.
Dr. Swain?
Yeah, I think the longer term is so essential. Now that we know the TAVR data at 7 years and the degeneration, that, you know, partial repair of a valve, does that really work? Things of that sort. We've just got to go over the 2 years and even over the standard 5 years.
Dr. Zuckerman?
Yeah, I'll just agree with that.
And then that leads us into how to best consider the impact of adverse events associated with heart failure technologies while balancing potential for improvements. Dr. Swain?
Well, again, when we look at these composites that are all weighted the same, we see devices that say they're better than surgery because that's totally driven by amount of blood transfusions, or prolonged ventilation defined as 25 hours on a ventilator counts the same as death. So I think that one has to have a qualitative judgment and somehow hierarchically look at these, because it's a huge problem in these trials when the least AE drives it completely.
Any other comments on the impact of adverse events or how to collect that data?
I just want to get back to Larry Allen's work, because I think it's really important that we capture the individual serious adverse events, which have a different implications for patients. Like stroke isn't the same as bleeding, isn't the same as an infection. So I think when we have high-tech, high-resource interventions, we need to capture each one of those and talk individually to patients about it, even though for the standpoint of a device efficacy, you might lump some of those together.
I echo that. I mean, that's incredibly important, especially when we talk about very risky devices. Some patients are willing to take some risk and not others. So,
Dr. Fish? Thank you.
So I think that including patient-reported outcomes in the adverse event reporting would be useful. In cancer land, we have this PRO CTCAE as sort of a newer measure, whereas adverse events had previously been, ascribed by the clinicians. And being able to measure the patient's data over time at a distance, so they don't have to be face-to-face at the time of a clinic visit, through digital engagement would also be useful, and might allow us to get very early data and also be able to measure late effects of some of these devices that are in for a long time.
Great. And now, Dr. Siegel?
And just to comment about the preferences, the question is phrased here sounds like it's patient preferences about treatment, but it's probably patient preferences about outcomes and how they value different outcomes, I would think. Right? Well, I guess it could be either, but that's how I would interpret it.
I think their feelings about treatment are determined by their feelings about the outcomes. And that could bring us to the last discussion point before we conclude, which was how to balance the short-term benefits and harms, it says, with treatments that may decrease length of life.
So I'm going to charge in for this one, and it relates to the last thing. I think everybody said it, but I'm going to say it again, hopefully more clearly. Often we measure as physicians the benefit and harm, and then we sit in a room and we try to calculate that benefit-harm ratio. A thrombotic event, a bleeding event. What is that event, benefit and harm on 3 months, which is different than at 10 years or at 5 years? And the research methodology usually is asking people the standard gamble. You know, how much harm would you be willing to, take for one potential benefit? And that's different at different time points. And those measurements of the standard gamble are usually done randomly, not within the clinical trial. But it's the participants, not the subjects in the clinical trial, who are best poised actually to tell us, not us judging, that relative risk and benefit. And it would be different probably at study start, full of hope, at the time of the event with the stroke, and when the stroke recovers 5 years later. And that's a period of research we've barely even begun, but very important.
Dr. Zuckerman.
Yeah, I guess I would just add that in my experience, patients are, they live on hope, and they want to think things are going to work out. I mean, maybe as patients get older and sicker, that changes. But just generally, they're very optimistic that if something has a 10% chance, there'll be that 10% chance of being helped, and if there's a 10% chance of dying, it won't be them. So it's hard to balance that for patients because, it's their lives, and they're not going to go into this in this logical, statistical way. And we just have to do the best we can to provide that information, but how it's received is different.
I'll let, Dr. Berliner, and you'll have the last comment, and then we're on.
Yeah, so I think the way that the kind of decision aids that Picori talked about, that's the way to help patients make individualized decisions about risks and benefits. And another project that we're working on at ARC is building off of our Force TJR orthopedic registry, where we're funding the development of an app where patients put in their characteristics, then built off the data in the app, the app will tell them what their most likely outcomes are, both risks and benefits. And I think that those are the kind of tools individualized to individual patients that will really help patients make decisions.
Thank you. Clyde?
I think this is easier in clinical practice than in trials, because when you're dealing with people that have advanced disease and are symptomatic at rest, they simply want to feel better, and nothing else gets into the equation. And we deal with this on a regular basis. In a trial where there's a signal of harm, we're not comfortable with it going forward. But in practice, we deal with this all the time.
Well, thank you. I want to thank all of the panel and the speakers. Oh, Dr. Cruz.
I'm sorry, I just wanted to make you said the last comment.
Yes.
I think something that may be worth thinking and including into in the design of these studies is something that has been somewhat but not completely studied, which is the framing of the decisions for these patients. That is to say, it's not the same to say you have a 90% chance of dying as saying you have a 10% chance of surviving. And so when people, and the difference, there was a study by Tversky and Kahneman in terms of how this is framed. And people become risk averse or risk taker depending on how those options are presented to them. But I'm not sure that in situations like this or in stroke, which is my area, have been thoroughly studied.
It's a very interesting field, and I listened to kind of their talk recently, and I think people are, and patients and doctors are not the most rational. We would make we'd make a different decision on the same data depending on how it's framed. And that maybe will be another MEDCAC, but for now, I think this was really a very interesting and innovative and creative topic and discussion. I really appreciate all of the speakers, the panel. I would say I got here before 6 this morning, and Maria already had all the sign-up sheets out, all the badges out, so I just want you to make this run. Thank you so much. And Dr. Chin and Dr. Caños. And thank you to the MEDCAC panel. I think everybody really contributed to an incredibly, as I said, informative. I learned a lot. We talked about a lot of tough issues. Thank you so much. And I'll let Dr. Chin make the concluding.
Well, thank you, Rita. And so I'd also like to thank the panel, our invited speakers, and our guests that's helped us out today. I think it's been very, very interesting. We've gotten a tremendous amount of information to help us. I think we're very appreciative to have a renowned panel with us today of experts in heart failure. And I'd also like to specifically thank Dr. Redberg for not only chairing this this meeting, but also the past few number of meetings that we've had, and she's been great to work with. So thank you.
My pleasure. It's great to work with.
I just would like to, I'm sorry. I would just like to let everyone know that all the changes that was discussed during the meeting, they will be reflected on the questions that will be posted to our coverage website, just to let you know. Okay? All right. And for the panel members who are on the shuttle is here and waiting for you. All right. We gotta go.